Having undergone specialist training in Moorfields Eye Hospital in United Kingdom, I had returned to my hometown of Ipoh in 1974 with the aim of providing affordable, quality eye care services to my patients. LEC Eye Clinic was founded at that time, and from being a solo eye care practitioner in this clinic, LEC Eye Centre was subsequently born in 1999 with the inclusion of 2 other consultant eye surgeons. Since then, we have grown to become a Ministry of Health recognized day surgical centre, and to date, LEC Eye Centre is the largest private group practice in Perak with 4 consultant eye surgeons.
LEC Eye Centre is a one-stop comprehensive eye specialist centre, and we're able to cater to all the eye care needs of our patients. We pride ourselves in having the most advanced technology to provide the best outcomes for all our patients. We have premium cataract surgical services, and this involves the acquisition of the first Lenstar optical biometer in Perak, which is actually a laser machine used to measure the eye before cataract surgery. We also have another advanced machine called the Varion Image Guided System, which is actually a precision machine that provides digital marking during cataract surgery. Now, aside from this, we also provide retinal services, and this includes the management of retinal detachment, age-related macular degeneration, and diabetic eye disease. We acquired the first in Malaysia sweat-source OCT angiogram, and this actually allows us to take high-definition images of the retina and better manage these diseases. We also want to make sure that we are always accessible to all our patients, and they can make appointments to see us with a click of a button via our online appointment system.
At LEC Eye Centre, we have our in-house optometrists who are vision care experts responsible for accurate testing of spectacle power as well as contact lens fitting. They also provide vital support to our LASIK services. At LEC Eye Centre, we acquired the first in Asia wave-like refractive suite in 2011. One of the fastest lasers in the market, this unique all-in-one suite connects the machines used to measure the eyes before surgery with the laser machines, so all treatment information is sent wirelessly and allows surgery to proceed seamlessly and with unparalleled precision.
At LEC Eye Centre, we recognize the increasing problems of nearsightedness or myopia amongst children nowadays, and we have in place a myopia control program to combat this. This program involves the use of myopin and eye drop, which has been found to be effective in slowing down the progression of myopia in children. So this program aims to increase awareness about myopia and allows our team of doctors, optometrists and nurses to work closely with parents to manage this epidemic which is sweeping the world. A key component of this program is the use of appropriately prescribed eyeglasses, for which our subsidiary company, Eye Care Optical, will be able to provide. Aside from children eyewear, a wide range of adult eyewear is also available.
Hi, good evening, everyone.
Yeah, good evening, good evening.
Good evening, everyone.
Good evening.
Welcome.
Good evening.
Okay.
Okay, good evening, ladies and gentlemen. I'm Anna Lam from LEC Eye Centre. I will be your host for this evening. It's my pleasure to welcome everyone to our first LEC webinar series. So can everyone hear me loud and clear?
Yes.
Yes, yes.
Okay,
Yes.
that's all right. So I hope everyone had a pleasant dinner, and thank you for taking your precious time to join us for this vision care during COVID-19 pandemic.
Yep.
So kindly pardon us, would there be any shortcoming during this webinar, as we will try our very best to assist you. All right, so before we proceed, I would like to state some housekeeping announcement for this webinar. So for those who are new here, if you have any queries, please do not hesitate to message us in the chat room. So during the speaker presentation, we will mute all the attendees to avoid any noise interruption. And during the Q&A session, you may either type in your question in the chat room, or you may raise your hand and unmute yourself to ask the questions. All right. So for those who have experienced low internet bandwidth, I would advise you to turn off your video during the presentation to avoid any interruptions on your viewing of the slides from the presenter. So you may turn on your video during the Q&A sessions, okay?
Okay.
Brief introductions of my speaker tonight. So just let me share a screen. So our guest speaker tonight is Dr. Lee Man Wai. All right, he is a medical director of LEC, graduated from University of Manchester, UK, and started his ophthalmology training in Singapore National Eye Centre, and as well as a fellow of Royal College of Surgeons, Edinburgh. His subspecialty interests in vitreoretinal surgery, and he completed his fellowship training under the mentorship of Professor Ian Constable at Lions Eye Institute in Perth, Western Australia. So Dr. Lee has been very active in ophthalmic research and also involved in many clinical trials during his career, as well as a key opinion leader in many national and international conferences as well. He also covered over 20 scientific publications and contributed several book chapters. Dr. Lee, existing, is also a visiting consultant at Perak Community Specialist Hospital and KPJ Hospital as well. So without further much ado, I will pass this whole session to our speaker tonight for his sharing. So can everyone please give him a warm welcome, a virtual welcome. Dr. Lee, pass to you now.
Thank you, thank you. So thanks a lot, Anna. And of course, welcome to everybody. Thank you for all our new people who are new to LEC and all our existing patients as well, or family members. I think we are very pleased to be able to bring you our first webinar. I hope this will be the first of many, because I think we are in a rather unprecedented new situation now with what's happening in the world. And I think we are looking to always reach out to people in different ways. And this is one of those ways that we hope that we'll be able to take forward, even when things come back to more normal ways, because, you know, there's no better. I think you just mentioned, Madam Wan just now, you're back in KL now. Everybody is from different parts, everybody from Ipoh or others from coming from KL, as you mentioned. So we can actually enjoy information sharing from the comfort of our own home. So I'm just going to share my screen, if you don't mind. Just give me a quick moment. So today's talk, I thought I would just share a little bit of information about COVID, of course, but I won't dwell too much on it because I'm not an expert in COVID. You know, as you know, Anna very briefly and kindly introduced me, and I'm specialized in eye care, of course. But I thought it's a very appropriate time to talk about COVID because it is definitely what's affecting all our lives. And this is also something that has some relevance to us. And at the same time, I would like to also show what we are doing at LEC to actually look after our patients, and that in some ways it is still business as usual, because other eye conditions or other diseases, not just eye, don't stop. I think COVID is on top of everything else, so people still have eye problems and we still have to cater to those needs. So we're talking about vision care now during COVID-19. Technical issue straight away. Okay, so who are we? For those of you who don't know us, we are actually have a 40+ year history in Ipoh, and started off, I think the history can be found on our website, some 40+ years ago by Dr. Waisili, my father, and subsequently became a group practice some 20+ years ago, and now we are fully accredited MOH Malaysia by Ministry of Health Malaysia, a day surgical center, and specializing in eye care. Our facilities are such. Those of you who have not come to visit us, please do, but I don't mean that in a way to wishing you illness, but if you do need our services, please come and see what we can do for you. So these are some of the images that we have. This is our operating area, on our first floor, our daycare services, and our operating theater suite. We have 2 suites there where we are doing surgery. Over here is a colleague on my left side here, as you can see, operating, and that's me on the right side. And this is how eye surgery is done. I'll go into that a little bit more detail afterwards. We're going to talk a little bit about the services we provide. I think by far the most common and very important part of our service is cataract surgery. We have a lot of different instruments, and as surgeons, we like to call them our toys. A bit expensive, but yeah, they are our toys because we use them very well to actually provide the best care we can. And I'll elaborate a little bit more about these things that we do. As mentioned earlier, I'm also subspecialized in retina. So what happens is the retina is the nerve layer of the eye, and I won't go into too much detail, but there's a separate part of the eye which is also very important. And certain blinding conditions, as mentioned over here, you will see that I do deal with, and my colleagues as well. So retinal detachment, diabetic eye disease, macular degeneration, these are some of the things the retinal service can cover. We also do wavelight in terms of LASIK or laser vision correction. Wavelight is our platform. We were fortunate to obtain this platform, I think at the time, some 8-9 years ago now, which remains to be the only unit in Malaysia, and it's actually served us very well, and very pleased, and hope to have had very pleased, very happy patients using this platform as well. We always pride ourselves in trying to get the best and most up-to-date instruments so that we can look after our patients. So this is one of the things that we obtained fairly recently. This is like an MRI scan of the eye actually. Not the whole body, but this one gives us very high definition detail of the eye and specifically the retina. And we come up with a lot of information which actually helps us make decisions about treatment and diagnosis for our patients. So we managed to get this Triton series of machine about a year plus ago, 2 years now. And it was the first one that we managed to procure in Malaysia. We also have another branch of service that we provide for our patients. These are optometry services, which actually means that we can have patients that require glasses or contact lenses. And we have 3 optometrists with us that do very good work and work together with the eye doctors to actually provide the best in terms of prescription power to correct short-sightedness or nearsightedness, far-sightedness, astigmatism, and presbyopia as well. We have our own optical shop, which is just down the road actually. If you have visited us along the road from, we are at the corner at Sharon Green Hill. And if you go a little bit further down, we have Eye Care Optical, which is also our subsidiary company, and provide glasses for our patients as well, at a good discounted price, of course. So as mentioned earlier, I'm the medical director of LEC, so I'm in charge of all the medical services there. And I'm an eye doctor and ophthalmologist. Comprehensive, meaning that I cover quite a lot of general ophthalmology and in detail, as well as subspecialized into retina. So today, going into the topic of vision care, so what is it that I will be referring to with relevance to COVID? Very briefly, I think we probably have enough information about COVID. I mean, before perhaps 4 or 5 months ago, we never knew what this thing is, but now we are probably a little bit of experts, if not from all the social media, passive diffusion of information into our brains. So we should know what COVID-19 is. And it actually stands for Coronavirus Disease 2019. And that's when it first started. It was first discovered in 2019 in China. So what it is actually, it is a virus, it's a coronavirus, SARS-CoV-2. So SARS, or it's really severe acute respiratory syndrome coronavirus, is 2 because the first one was the one that was causing SARS all those years back. So this is a different strain, and it's actually got a zoonotic origin. Zoonotic means it came from animals. Of course, there are a lot of speculation about bats and all that. Nobody still really knows and has proven where its origin is. But most likely it has come into close contact with humans and came onto our species, and now is being propagated human to human. It's very contagious, and we know that there are different numbers out there, but on average, we know about 80% of people that do catch it may have no or very mild symptoms. They recover well, or they don't even know they have it unless you get tested. About 15% do get significant or sick enough that they need admission to hospital, and about 5% do get very sick. And when they get very sick, there's a small percentage of these that do die from it. So at the moment, why are we so worried about this? Because there's no cure and there's no good treatment that we know. So we don't know who's going to catch it and who has it and who might be passing it on to other people or even to ourselves. So these are just brief slides. I'm not going to go into detail as to what the symptoms of coronavirus could be. As I mentioned, up to 40–50% of people are asymptomatic, and 80% are mild symptoms. So when you talk about mild symptoms, you have a bit of cough, a bit of fever, get a bit breathless. These are those typical symptoms. But if you look into the details and if you read scientific literature, there are other things that can actually be associated as well. I think they have children that talk about they present in different ways. There are now reports about people getting brain infections, what we call encephalomyelitis. So there's a lot of things that are unknown. But these are the most common that has been listed, and those are the ones that are normally what people screen for. So afterwards, you will see a little clip that I'll show you what we actually do for our patients when they come to our center as well. So how to prevent, stop the spread of germs. I think we heard enough of this. So try not to touch your face, wear a mask, don't cough into the open air. That's why we have masks. Always sanitize your hands, and as best as possible, social distancing, so we don't go into big crowded areas, or if we do, we have to maintain a good distance of at least 1 meter. So these are some of the directions that we have had worldwide from the World Health Organization, as well as our DG has tried to push it through into our heads over the past few months already. So what has been the impact of COVID-19? I think this is public data. This is from a website called Our World in Data. And really, this is just a data to show, if you look at the X and the Y axis over here, the Y axis will show you the number of cases, X axis will show you, the number of confirmed cases, and the Y axis, the number of confirmed deaths. So Malaysia has done quite well, fortunately. I think if you see over the past few months, we have been stagnating in terms of number of cases. But there are increases now. I think if you follow the news, we're still getting sometimes single digit, sometimes double digit numbers, but not a high number of deaths as opposed to some of the more affected places in the world. But some might argue, whether this is a true number, but that remains to be seen. But I think we do feel that in Malaysia at the moment, we are not the worst hit. If you look at all the news that's going around about how some other countries are really bad. So we're not doing too badly, but doesn't mean that we can relax. So essentially, if you look at this graph, we are somewhere in the middle, which is not a bad place to be, but if we could be way down here, of course, that's good. But at the same time, there is still work to be done because this is still a very new disease for everybody. So just to highlight a few little pointers to make sure that people understand that why we still need to be careful in the presence of COVID-19 is because if you look at this graph here, it shows case fatality rates. I think the definition of case fatality rates, it just means that the total number of deaths which are confirmed from COVID-19 divided by the total number of confirmed infections. So these are people that have been tested. But if you argue, the number of people tested, we still don't know. So basically, these rates are just an estimation. But if you look down, further down as you get older, 70, 80 years old, see your rates, or rather the risk of fatality, meaning of dying from this, becomes very much higher. So if you're very young, for those of you who are children, perhaps very, very unlikely to die from it. So for myself, in my 40s, then you see the risk is still not very high, but if you move on to the 70s and 80s, then the risk gets significantly higher. So in Italy, you see the 80-plus-year-olds, 1 in 5 have been known to actually die from COVID-19. So we need to be mindful of that, because at the same time, in our center or in our specialty, we deal with a lot of aged population, because that's the population that has eye problems. The other thing that has been reported is the fact that if you have underlying conditions. So over here is another graph that shows that if you have diabetes or heart problems or hypertension or cancer, or anything that actually affects you in a significant way, you are also at increased risk of succumbing to this COVID-19. And this is data from China. And of course, we know China was the first to report the condition, and has currently, if you look, a lot of information and research coming up from China as well. So the impact on us worldwide is how he's looking at the deaths and the infections and the infection rates. And just remember that the older you are, the more likely you are to get a severe infection, or at least have a severe outcome from the infection. And if you have underlying conditions as well. So for those of us who have aged parents or who have underlying conditions, I think we have to be careful. Now, aside from that, what are the social economic impacts? I think we're always, as a government, I think it's not a good place to be, in the sense that they have to try and balance between trying to save people's lives at the same time not trying to crash the economy where people can't make any more money and suffer because of that. But businesses have been closed worldwide, similarly in Malaysia for the initial period, at least during our MCO earlier on. Schools are closed, so children are stuck at home. And there's no tourism, as we know. I think Ipoh itself has suffered as well. I think we do get even, well, perhaps domestic tourists, but not so many from other countries, but we do get them. And you can see now, if you go into Old Town, you know, there's, well, now it's a lot better, but in the peak of MCO, there's a lot of impact because there's no tourism. And we know tourism and tourists bring and adds to the economy and keeps the economy thriving. So this is an example of all the planes that have been grounded and in the different parts of the world. So personally, how has it impacted us? I think lifestyle changes. I think this is an image that's very familiar. This is in Ipoh. I think we are very used to people pointing a gun at our heads now, wherever we go. So you got a gun pointed at our head. We put our head forward for them to actually pull the trigger. Why? Because they are testing and screening our temperature. And now we have apps to actually screen, to actually tell people that we are low risk and that you have to take down details. All this is still so that something that's been sort of thrown upon us because of this COVID-19. So there are changes to our lifestyles. We can't go out as much, and when we do, we are trying to limit our movements. And of course, everybody has hand sanitizers. The initial part, everybody is scrambling for hand sanitizers. They're running out of that. I think we have enough supply now, but we always carry that to make sure our hands are clean. And this is another thing. So we're talking about webinars. This actually is a screenshot I took of all our LEC staff, because we are also holding meetings amongst ourselves. We're not a huge company. We are small to medium size, so we still have 20, 30 staff that we need to try and engage with each other. So this is one of our sessions that we had recently, and just took a screenshot to show that that's how we've been doing it, and hence moving on now to actually reach out to the public with this webinar. So moving on to the gist of things, and how does COVID in your eyes, how is that linked? I think those of you who have read will know that COVID can actually affect our eyes. There has been reports of causing conjunctivitis or a pink eye as a form of infection, because COVID is actually due to a coronavirus, and that virus can actually affect us and cause an infection in the eye. It is not common. I think the reports that have come out say that it is a very uncommon manifestation of COVID-19, but it has been reported, and usually in those which are actually more sick. And typically it can be just redness, irritation, tearing, discharge. And because we do see this very commonly, conjunctivitis is very common when we see in our center, but we have to be careful as to protect the patient as well as ourselves from cross-infections. So this is a paper, a scientific paper I just highlight. It's actually from China again, because they were first to describe a small group of patients of which conjunctivitis or pink eye or infection was reported in 12 of 38 patients. and it's usually more common in patients with severe COVID-19. So it can affect the eyes. Now, it's the more, not scary, but the more pertinent thing is that it can be transmitted through our eyes. So we may not have any symptoms, we may not actually have conjunctivitis, but our secretions, meaning besides our saliva, our tears, and other bodily fluids could transmit COVID-19. So infected droplets can actually fly and land onto our face or onto our eyes, and we can get infected that way. Or perhaps your tears can actually have a population of virus, which particularly for doctors that actually, or nurses or healthcare staff in our clinic perhaps, when they do have to handle and manage patients. That's why we have to be very careful with our hand hygiene, because we could be potentially touching tears and things like that. So that can be transmitted. So the importance is wearing a mask, so that we have all our patients wearing masks. I think you should be wearing a mask now. In fact, from the 1st of August, I think our government has told us that we need to wear masks when we go out into public places. And this is just not so much to protect yourself, but if you think about it, you are actually trying to protect other people, because you don't know whether you have it yourself, you haven't tested yourself. So when you wear a mask, when you talk, or when you sneeze, or when you cough, you are not coughing into their environment, and you're not transmitting your droplets to other people in case you have it, as much as it's protecting you from others. So it doesn't eliminate or 100% cut off the transmission, but at least it gives you some protection. So it's important that you remember that you need to wear a mask. So what are the changes that we have actually undertaken at LEC since the beginning of the MCO, or since COVID-19 was thrusted upon us? So there are some changes, and I'm going to play a little video here for the next couple of minutes. We just watch, which will actually tell you about the things that we have done that's different now. Okay, so basically that was just a video to highlight some of the changes that you will actually see. I think may not be specifically unique to us, but at the same time, you see we do temperature screening. We take a travel history to make sure that, unfortunately, high risk people that are coming back from high risk areas or high risk countries, we may not be able to see you. And at the same time, there's a lot of cleaning and disinfection going on. We have our cleaners cleaning the floor, wiping the chairs, and wiping our instruments and everything in between patients. And you see everybody's wearing a mask, and gloves as well. So these are some of the changes we are doing to try and protect ourselves and our patients, of course. And similarly, during surgery, we are doing the same as well. Now, should you require now to perhaps come and see us, there are different ways that you can make your appointment to come and see us. And I would advise that the best is to try and make an appointment, because currently we are trying to manage as you see, there are little crosses on the chairs in our center so that we are maintaining social distancing for our patients. We're trying not to overcrowd the center because we don't want people to be too tightly packed in a closed environment and risk transmission. So if you can make an appointment to come in, that would be best. And we try to get you in and out as quickly as possible. So you can call us. I think our number is available. You can go to our website and actually email us with our inquiry. You can go to our Facebook page, send a message, PM us, as you call it, personal messages, and we can actually make appointments for you there. You can go to our Instagram, perhaps not so much, most people like Facebook better. We have a YouTube channel as well, and we also have an app which actually allows you to make appointments yourself and look at when are the available slots. So for example, this app is called Encomed. It's downloadable in the Apple Store as well as the Google Play Store. So this app itself, when you go in, you will see, you put in LEC Eye Centre, for example, this is for myself. You can search for the different doctors as well, and also for our Sitiawan branch. You can click on make an appointment, and it will take you to a screen, and you choose the date that you want, and you can see the available slots that you can put in. So when you put in a slot, an appointment, you put in your name, you put in your phone number, you will get a confirmation via SMS and a reminder as well. So that's one way that we are trying to get our patients to actually manage their appointments better, and so that it's actually easier to access to us. So we are also doing different things now. I think we started as an MCO, started to actually try and get medications out to some of our patients who are not able to come. As at the time, the movement control order was strict, and some of our patients coming from out of town, perhaps not as far as KL, but even sometimes from KL, further outskirts of Perak. So they're not able to come and get their medication. So we have actually got a delivery service, which we are maintaining. They have patients which are on long-term eye drops for glaucoma, perhaps, and for other conditions that require long-term eye drops and not able to come and get the drops and not able to get it at a local pharmacy. We are delivering to our patients. So this is some way that you can do it. Again, through the different social media channels or just a phone call or a WhatsApp, and we can actually send things out to you. The other thing we're doing, we are also offering online consultation. I think it's something that's still quite new, but something that we are doing. It's not rocket science. I think we're all very familiar with now face-to-face communications, either with the laptop, as easy as WhatsApp or FaceTime or all the different Facebook app as well. You can do that. So we are offering online consultations for our patients who feel that they're not able to come in and just want some advice, perhaps. I know it's not easy to examine your eye because we can't touch you or examine you properly, but if you have any questions or you have any concerns about some treatments you're on or some symptoms that you have, you can actually arrange to have an online consultation where one of our doctors will actually come online face-to-face and talk to you and give you some advice. And if you really need to be seen, then we'll have to get you in, of course. So another option for you to reach out to us or for us to reach out to you. Having said that, now I did say earlier that we're going to say that despite COVID, I think that's one thing that even though it's not likely to affect our eyes and it's not likely also to make us very sick unless, in the different risk groups, other conditions are still continuing. I think you have also read about how some of the healthcare services or hospitals in some of the other countries have been overwhelmed for people with COVID, that, people are dying from other diseases, the usual things like strokes and heart attacks. So similarly for the eye, the patients still have eye problems, it doesn't stop. So our business as usual continues. And I mentioned earlier that a very important part and very common condition that we deal with is cataract. So cataract surgery at LEC, I've seen this slide earlier, we have different instruments to cater for that. And we pride ourselves in offering best care that we can give in terms of providing good outcomes using all the technology available to us, the latest technology. So this instrument here, you see, we have a lot of toys, like I said. So this one is one of them that is very important to us. Why? Because we have to use it to measure your eye before you go for cataract surgery, so we can accurately choose the lens power to put in so that we can tailor or correct your vision according to your needs. I'll go into that a bit more detail in terms of correcting your vision with cataract surgery. This is another instrument that we have for a few years now, and it's almost like a digital guide where you actually use this machine to take a snapshot, and it actually behaves like a digital guide during surgery. So, you know, nowadays we use computers for so many things. So this machine, again, does the same. So the image that you take before surgery is used during surgery so that we know exactly where we want to put our incisions to operate, where we want to put the lens to position, so that we can be as accurate as possible. And this is the main workhorse, which is the machine that we use to remove your cataract. We'll go into detail as to how that, well, not in detail, to a little bit more of an overview of how that's done. So contrary to a lot of people's belief, it's not really laser, but laser cataract surgery is available. I'll talk about that a little bit more. But this machine is the workhorse that removes your cataract, and it's called a Centurion. So the one that we have here has got a very unique way of controlling the environment within the eye so that it's making it as safe as possible as we operate. And this is from an American company and one of the market leaders, if not the market leader in terms of cataract surgery. Now, I like to always talk about myths about all conditions, but cataract is the topic that I'm going to mention now. Why do I say myths? Because there are a lot of, not old wives' tale, but a lot of beliefs that, you know, the lay people have that may always be true. I find that, you know, having been back for over a decade now, that I see a lot of the older population that have cataract have certain misconceptions of what actually cataract or cataract surgery is. So very commonly, the first myth I hear, I think, is people think that cataracts actually grow either on top of the eye or inside the eye, that is actually growing. So it's not something that actually grows and comes about from nothing. It's like, it sounds like an abnormal cancer, like it's growing. It's not really something that grows, but more so if you look at how the eye is. So this is a picture of, this is a cross section of the eye, and this is our normal eye as we see it. You know, the black part is the pupil. If you look at the cross section, actually we are talking about the lens. So the lens is actually what the cataract is a result of, because as we age, this lens tends to get dirty or get cloudy. So it's like a window that's getting dirty because it's not being cleaned. So the eye works like an optical system, like a camera. So you have a lens, and over here, the retina, as I mentioned earlier, is my area of subspecialty, is like the film of the eye. So we don't have film anymore because we all have digital cameras, but basically the eye works like a camera. So we're talking about the lens when we talk about cataract. Quick short video. This is not my own video, but it's a video that I find does explain cataract and cataract surgery quite well. So just bear with me. I'm just going to play the little video again. Another video.
Cataract is a common eye condition that affects millions of people, particularly as they get older. Everyone, if they live long enough, will eventually develop cataracts. Over time, cataracts can often affect your vision, causing symptoms like blurriness, poor night vision, or glare that gradually worsen if the cataracts are not removed. Fortunately, your eye surgeon can remove your cataracts and, in the vast majority of cases, restore good vision.
In the healthy eye, the lens is clear and allows light rays to pass through unobstructed. As a cataract forms, the lens gradually becomes cloudy. As light passes through this cloudy lens, it is no longer clearly focused on the retina, causing images to appear hazy or blurred. Usually with cataract surgery, a small incision is made in the eye. The front portion of the thin outer covering of the lens is opened to allow removal of the cataract inside. The cataract is gently broken up and vacuumed out. Then a folded lens implant is inserted through the small incision and into the capsule, where it unfolds and permanently takes the place of the clouded natural lens. With the cataract removed, the new lens implant clearly focuses light rays onto the retina. The power of the lens implant is selected for your individual eye.
Before scheduling the surgery, you should discuss your vision goals with your ophthalmologist so you clearly understand what cataract surgery can and cannot do for you.
Okay, so that was a brief introduction and overview of cataract and what the treatment is. So symptoms of cataract actually are varied. I think they mentioned just now in the video, they talked about glare, blurring, and A lot of time I find that most people that have cataract will come to me and say their vision is blurred. But their vision, but when they talk about blurring, it could be just something like a little smoky or hazy as depicted in these pictures here, how vision could be through a cataract. So these are some of the symptoms. So what are the causes? So most common is age. So as mentioned, it's inevitable. All of us will develop cataract. Doesn't mean that we have cataract surgery when we do get cataract straight away, but at different stages of our lives, depending on the individual, we will require cataract surgery if we live long enough. The other causes, of course, hereditary. I think you can get genetics, which some families will have cataract as passed down because of genes. So that is one possibility. Other medical problems can give you cataracts more frequently. For example, is diabetes. People with diabetes are more likely to get cataract at an earlier age, purely because, you know, when you have problems with your sugar control, like in diabetes, it can also affect your lens. Injury to the eye can always develop cataract, cause cataracts, which doesn't mean that they come straight away. If you get a bad injury where the eye is stabbed by a nail or something, which I do see sometimes, then you can get a cataract straight away. But if you do get an injury, for example, you fall or you hit your eye on the corner of a table or something, at that time, you might actually get pain, bruising, and then after that, the vision comes back to normal. But your eye could then develop a cataract, perhaps 5 years down the line, or it will be somewhere further down the line, the cataract can come. So it may not be immediate. Medications. Some medications, particularly steroids, have been known to cause cataracts. And some people who are taking steroids chronically or in the long term, for example, either for asthma, some people use inhalers, certain creams that they use, people with very bad eczema, they use a lot of steroids. You can also get cataracts earlier. Now, if you get a lot of sun exposure, people that work in the sun all the time and don't protect their eyes well, can end up with actual cataracts earlier. So treatment of cataracts. So the most simple way to do it is glasses, because you have early cataracts. What happens? It doesn't mean your vision is blurred. It does mean it's blurred. What I mean is it can be corrected still. When you go to the optical shop or the optometrist, optician, they can actually make a pair of glasses for you and say, oh, I see better now. So glasses can correct cataracts when they're early enough. But at some point, when the glasses don't work anymore, then definitely the only way we can do it is surgery. So that's the main thing that we have to do to cure cataract, is to operate. Now, the other myth that I find is people always ask me, is my cataract ripe? In the sense that, is it ready to be done? So they've been told that it has to get to a certain stage, or where they have to get to a certain level where they can't see before they actually have it operated on, which is not so much true anymore, because the way that I would actually tell my patients when it's the time to do it is basically not when I tell them, but more so when it's interfering with your life, with your daily activities. If you can't read, you can't, some of you are still working. I think nowadays the baby boomers may be working till their 60s or 70s or beyond. If you can't do your job properly, you can't drive safely, or basically it's just not able to carry out the things that you want to do on a day-to-day basis well, like reading or watching TV. Or sometimes for people, particularly those who are diabetic, I have patients where they require to give themselves insulin jabs and not able to see the drugs properly, so they can't take the medication. Then it's something that's important that you have to do it. So those are the times when cataract surgery should be done, when it's impacting significantly on your lifestyle. So that's the time. Now, cataract surgery, I'm not sure those of you who know people who have had it or might have read about it, but I have had patients who said to me, you know, I believe that you take my eye out, put it on the table, and then operate and then put it back in, right? Is that how you do it? I said, no, that's not the way that cataract surgery is done. In fact, we've come a long way as to develop a very safe technique for cataract surgery now, where you don't need admission to the hospital anymore. You have operation and you go back the same day. But it is still surgery, so we still take it very seriously. But it is not as big an operation as you would compare to somebody that goes for maybe a hip operation or heart operation. Nothing that way. It's way much more straightforward. So this is a setup in our operating suite, how we operate. Now, it does look very busy. There's a lot of wires everywhere. Why? Because we have this very crucial instrument, which is a microscope, and we operate looking down the microscope. And that's why afterwards you'll see a video of me doing surgery where you don't see my hands, you only see instruments moving inside the eye. And that's what actually happens. So you need a microscope, so it's microsurgery, and the machine is there, and the patient is somewhere underneath here. So believe me, there is a patient there, okay? So what we do is we do most of the time now what we call topical anesthesia. So we give some eye drops to numb the surface of the eye, and it's good enough to carry out surgery. But on top of that, to ensure our patients are safe and also comfortable and not so anxious, we also give a bit of sedation. So we monitor their heart rate, their BP during surgery, and we at the same time give them something so that they are a bit calm and sort of somewhere between falling a deep sleep, but not quite fully asleep. So you're just more calm. So we just do that as well. So we don't just put eye drops. So this is how, if you do a close-up of how the actual surgery is taking place. So the patient's under there and just the eye is exposed and there's instruments going in. So cataract surgery is done with laser. That is one thing that people always talk about, laser and laser surgery, because laser is very commonly associated with the eye. I think we use laser for LASIK, but we also can use laser for cataract. But let me show you what is the common way and the most safest way that we have now. It's this long term here called phacoemulsification. Basically, it just means that we use ultrasound. It is a high frequency ultrasound, which is used to break up the cataract and basically suck it out, and you remove your cataract that way. So this is a video of cataract surgery. I'm just going to talk you through it. So as you see, I'm just starting off here with already 2 instruments inside. We use both hands to operate. If you go back and you see, we are looking down the scope, we're using both our hands. We're using our left leg to control the microscope, we're using our right leg to actually, or right foot, shall I say, to control the machine. So all the limbs are being used at the same time when we operate. And of course, you know, what's important is going on between our ears as well. Our brain also has to be used. So what we're doing here, if you see the animation earlier in that video, say we open a little membrane on the surface. So this actual cataract sits inside a little bag. So we open in the top surface, which we call it a capsule. So we open the front part of the capsule so we can access the cataract. Then we use these 2 instruments. So this big one here in my right hand over here is the one where the high frequency ultrasound is coming from. So you break up the little lens into small pieces and it gets sucked up into the machine. And this left hand here is an instrument that actually helps to break those little, break the cataract into little pieces, so that we can then remove everything through a small wound. So you see the incision or the cut that we make into the eye, in my case is about 2.2 millimeters. It goes up to about 2.75. It's less than 3 millimeter wide. And this small one on the left hand is only about 1 millimeter. So after we've taken out the bulk of the cataract can be quite hard. So we don't want to wait too long for the cataract to be too dense to operate, and that's why it's important that you don't wait till you cannot see, because very dense or hard cataracts are more difficult to remove, and you have to take longer time. And when you take longer time inside the eye, you know, things could go wrong and all that. So you don't want to wait too long. As you see, after you've taken out the bulk of the cataract, there's still all the little small sticky pieces that you have to remove. Now this is a lens. You see a little picture of the lens. The lens doesn't look like what we actually imagine. It's got 2 little legs. After I have a picture to show you. It's actually folded up into a little small, like a bokpiang like that. I think like a little, I don't know, chunking, like they call it. Like the spring roll. You roll it up and then it goes in, then it unfolds itself. It's actually made of plastic. And it's a plastic that has been proven to be very safe. It stays in the eye forever and doesn't cause any problems, and it doesn't need to be removed. As you see here, we also inject antibiotics to make sure there's no infection and all that. So this is how cataract surgery is done. So this is of course an edited video that took about 2 minutes, but in actual fact, my hands, it takes anywhere between 10 to 15 minutes to do a cataract operation in a standard case. Now obviously I'm showing you a standard case, but you know, there are cataracts that can be more complicated where they're actually very hard, or you know, sometimes the pupil opening is too small, or because of injury, the cataract can be tilted. You know, there are different scenarios which make cataract surgery very, very challenging. But we also do all of that in LEC as well, because we are equipped and trained to actually deal with that as well. But that is another whole webinar on itself. So now let's talk about laser. I think if you do enough research, I'm sure some of you who are very tech savvy and attending a webinar now, so I would expect that you do have information about laser cataract surgery, and that's something that has been around. It's not new, it's been around for at least 8, maybe up to 10 years. And why is it not really caught on? I can tell you 2 things. This is an example of an advertisement that was put up on the web that I just found. You know, this is in India, and people talk about using bladeless laser cataract surgery. So bladeless is a big term, for cataract surgery. It just means that you use laser. You don't need any instrument to cut the eye. You use a laser to do it. So yes, it can be done with laser. But what it doesn't tell you is that there is two machines here. If you see on this picture, this right side here is actually the same one that I just showed you just now, the Centurion, which is what you use. So this is the laser machine, and this is the machine that removes your cataract with the ultrasound. So you still need the ultrasound. After you've made the cuts so that you don't use the blade, you can actually cut with the laser, break the lens up with the laser, but you still need the ultrasound to take it off. So at the moment, that is what laser cataract surgery is. And it costs dollars. It's very much more expensive. And honestly speaking, it has not been shown to be beneficial or safer than the standard way that we've been doing it as I had shown you. In fact, interestingly, there are some centers in Malaysia that offer it, and there was this ding-donging between two colleagues, we should not name names, about one saying that this is safer, better, the other one saying that it's not. But this is just an article that was published in Star 2 years ago, where they had this sort of quite a public dispute on the newspaper talking about which is the better way of doing it. Now, doctors, as you know, have certain preferences on how they carry out the procedure. I'm not saying that one is a better doctor, one is not, but they both have good merits in the sense that they can still do cataract surgery very well, whether you use laser or use the standard way. But at the moment at LEC, we're not using laser cataract surgery. Why? Because we find that besides being possible to do it, it's not offering anything additional to what we are already doing, except for more money. So our patients have to pay more to get something which is almost the same as what we are already doing. So I think it's not quite worth getting our patients to fork out that much more to get a result that's almost the same as what we're delivering now anyway. So that's laser cataract surgery. Not quite there yet, despite being around for 10 years. It's still not very common. The other thing that I find some people are talking about is they say, just take my cataract out. I had patients ask me this, but don't give me a lens. I don't want a lens implant. I want to save money. I know the lens implant is very expensive because this the relative told me that, no, they choose this lens and I don't want a lens. Actually, it doesn't work that way because as I told you, the eye actually has to have a lens to function properly. So if you take out your cataract, which is actually a lens that's gone cloudy, and you don't put back a lens, then you can't work. It's like your camera, you take out the lens and you don't put back a lens, then how is it going to work as a camera anymore? So you can't. You need to have a lens. So this is an example of the different types of lens available, and most of them are in this kind of design. So you got a center part, which actually gives you the power and focusing and everything. And you have two legs. So these two legs, actually there are other designs, but this is by far the most common, or what we use at least. So these two legs actually provide stability inside that capsule, that bag that the lens used to sit in. So the cataract is taken out. So this lens sits inside that bag, and actually the legs actually try to give it stability over time. So it pushes out against the edges so that it doesn't move around inside anymore. So it's like you're standing between two walls and you just put your hands out so that you can actually be stable. So that's what the lens is. Now you will hear, if you do discuss with your eye doctor about what we call monofocal implants, you're going to talk about multifocal afterwards. Basically, a monofocal is an implant where when you put it in the eye, it actually gives you one focal point. So you can focus for distance or for near, but most of the time, you put it in so that people can see clearly for distance, and they still have to wear glasses to read. So that's what we call a monofocal implant. And it works very well. You get very good vision, but you still need glasses to read. Now, more and more patients are moving towards getting their vision corrected. This is what I'm saying by correcting your vision with cataract surgery. So gone are the days where you do cataract, after that you say you can see, but you still need glasses because people don't want those glasses anymore. So the next step up from a monofocal is what we call a toric implant, where the toric means that we correct astigmatism, or Cantonese call it sangkong, or in Malay they call it silau. So you correct all the distance blurring with this implant so that your distance vision is sharp without glasses. But you still need glasses for reading because this only corrects for distance. So people that use this are people that want to drive without glasses, use the computer without glasses, maybe play golf or do their sports without glasses, but they don't mind wearing reading glasses. So this is toric. Now, one more step up is what you call a multifocal now. So what you end up with having now is people that don't really like glasses at all. So they say, I want to be able to see without glasses when I drive, when I play golf, when I do my computer work, when I read my newspaper, I don't want to wear glasses. So this is what we use, multifocal implant. Now, when I say they don't want to wear glasses, of course, there are still instances if you want to read very, very fine print, like you take out a medicine label and you want to read, you still need reading glasses for that because those are very, very small prints. But by and large, if you talk about day-to-day, 90% of the time, you don't need glasses for your day-to-day activities. And the last one is what we call multifocal toric. That means you correct all your distance near everything plus the astigmatism. So this is the premium or the top of the range type of lens that you can have. And this is the technology that we have up to now. And this is how we can correct your vision when we do cataract surgery. So I won't go into too much detail about a simulator because really that one just tries to tell you how the multifocal implant can work for you, but it's not quite as accurate as actually predicting. It's not that good a predictor of how your vision should be. So the best way is actually to have a very good conversation with your eye doctor. So make sure, doesn't matter where you go to get your eyes checked. If you do have a cataract and you find out that you're going to have surgery, the doctor is talking to you about surgery, you must be able to have a conversation to decide what is the best option for you. So don't look at, well, do look at cost, but don't look at cost only. Don't say that give me something that's the cheapest or give me something that's the most expensive. It doesn't mean it's the best for you. I have patients that come to say, give me the best. So what do you mean by best? Is it the most expensive? It doesn't mean it's the best. Because you want to buy a phone, you can buy the top range phone or top range car, but you don't know how to use the functions, there's no use. So what is basically the most important way to choose a lens is when you talk to your doctor based on what your desires or your lifestyle is. Do you still work? Do you use your do you use the computer a lot? Do you use your phone a lot? Do you play golf? Do you do this? Do you play mahjong? Do you cook? You know, things like that is how your doctor will be able to help you decide which way to move in terms of what lens you can actually use. So very important to have a good conversation with your doctor. All right. But we cannot choose for you because we don't live your life. So we can't say that, okay, I think this is the best for you. But at the same time, we can just say, this is what this lens, this option can give you. Is this the right thing for you? So we can't say the best thing for you is this because we are not actually living your life or doing the activities that you're doing. So don't forget, any surgery still has side effects. No doubt in cataract surgery, it's very, very minor or very small risk of side effects, but it's still present. And you can get very, very bad outcomes if you get infection or retinal detachment, but the risks all in all are less than 1%. So in 9 out of 100 times, most people do very well, but we are still going to be aware and be careful that we do not expose ourselves to all these risks, particularly infections. You've got to look after yourself, use your eye drops, and then don't do anything to increase risk of infection, especially during the early period after surgery. All right, almost finishing now. I know I've been going on for a long time. So some final words just to summarize. Cataract is a blinding condition, but realize that it is actually something that can be treated very successfully with surgery. So don't delay if you do have cataract or you know somebody has cataract, make sure that you can actually get the treatment on time. It is a safe, pass and painless surgery. So actually speak with your eye doctor and actually make sure that you understand what options are available before you commit to surgery. So that's very important. So finally, I just want to close off by saying that, now we are facing, the new normal. As I mentioned, there is not going to be a return to the way things are anymore, not for a long time, because we have got no cure for COVID-19 in sight at the moment. There's no vaccine available in the near future, so we have to live with this. So what is the new normal? I think the future with COVID, I think we have to be able to protect ourselves, not just our eyes and our health. So make sure you have good practices. Don't touch your eyes and face, wear masks. For contact lens wearers, if you wear contact lens, we tend to touch our eyes a bit more, or you tend to touch your eyes a bit more because they might get dry or irritated. So be mindful of that. Perhaps wearing glasses may be a better option. Some people say that, the glasses might have goggles and extra layer to prevent people who actually sneeze in your face or something. But, we don't know that whether that's proven. But if you wear glasses, there are people that actually fiddle a lot with your glasses as well, because sometimes they slip off. So you got to make sure your glasses fit well. Otherwise, you're always touching your glasses and touching your face as well. So there are little things that we may not think of, but we have to be mindful of now. So always wash, disinfect your hands, your glasses, and don't forget your mobile phone. Okay, your mobile phone is the thing that we touch the most. Some people, for lack of a better way of putting it, bring it to the toilet. Look at it while they're on the toilet. That's not very hygienic practice, but I'm sure some of us do it. So disinfect your phone as well. Don't forget, and avoid rubbing your eyes, your nose, and your mouth, and touching your face. So those are just some safety precautions as we move forward and trying to live with COVID. So I thank you. I think I've taken up a good 45 minutes plus of your time now with this webinar. I look forward to answering some questions. I'm sure there'll be some. And if you do need to contact or reach out to us, call us, visit our website, go to our Facebook page, look at some of our videos and leave comments, or go to our Instagram. I think social media is something that readily available to all now. So thank you very much for listening. I hope I haven't drawn on for too long. It's a good 45 minutes there. And I look forward to more questions from you. Thank you very much.
Thank you, Dr. Lee. Any questions from the floor? It's either you can raise your hand, or you can actually type in your question in the chat room so that we can address to your question. Yes, Jerry?
Hi.
Hi.
Okay. I would like to address the question to doctor. It's regarding my eye problems. Okay, I'm like 44 years old, and I have myopia. It's around 1,000 plus. It's quite high power. Recently I found my vision, the eyesight not become blurred, it become distorted. The image become distorted, twisted, especially lines. So I suspect I got a AMD. Yeah, I mean, I need some advice from doctor here.
Okay, so myopia actually is a real problem that, we not only just understanding, actually we know about myopia for a long time, because it's basically, myopia means your short-sightedness. I think that's what you have. So over 1,000 degrees, your class is high myopia, and anybody above 600 is considered high already. Now, why do we worry about people with high myopia? Because your eyeballs compared to the normal eye is longer. So if you have a longer eyeball, what happens is all the tissues get stretched a bit more. So you're more prone to developing certain problems as you get older. So you're not particularly old, in your 40s, not that old, but 1,000 plus degrees is quite high. So what's likely that you do have, I think your concerns are true, that you may have some problems in your macula, because when you look at things and they look distorted, it just means that the area that is in the center, which is your macula, may have something that's causing the distortion. So that could be many things. There could be some fluid there. There could be some blood there. There could be a membrane on the surface that's been actually pulled tight because of the growth of your eyeball over time. And you can actually get splitting of the layers of the retina because of the length of your eyeball. So those are managed in different ways. And I think if you have this distortion, I think you do need to be seen more. So unless we get to see you or anybody wherever you are you in Ipoh?
Actually, I'm in KL.
Okay. Doesn't matter. I'm not saying you have to, take the next train back and see us, but definitely I think you need to be seen.
Is there any cure for this?
It depends what it is. So you have to have a look, and most of the time, I think you saw earlier we talked about OCT. We probably have to do that OCT machine that I was talking about, that we do a similar like an MRI of the eye. So we can look at that area in the macula and decide what is the problem. Now, if it's bleeding, if it's macular degeneration, which as a result and cause bleeding, then the treatment is actually medical in the sense where you need to have injections of medicine into the eye to actually stop the bleeding.
Surgery.
Not so much surgery, injections. Now, if you have splitting of the retina there, or you have a membrane, or you might develop a hole there because everything's being pulled, then that one is being treated by surgery. So without seeing you, then it's difficult to know what is the treatment.
Okay, thanks.
Yeah, sure.
Dr. Lee, there's a question from Jack. Jack he's asking, can I see anything during the eye surgery?
Yeah, good question. So actually what happens is when we use what we call topical anesthesia, we still put eye drops. So when we put eye drops to numb your eye, you don't feel anything, but yes, you can still see. But the difference is you're not going to see scary instruments coming into your eye and going to do things and things like that. You won't, because we actually have your eye exposed, where we keep your eye open and then we have light shining in. So what happens, you will see a bright light. Sometimes when you look at our microscope, you might see three small little lights. And then after a while, because it's like if you look at the light for a long time, for example, don't mean look at the sun. I mean, if you look at the light for a long time, so what happens, that light stimulates the retina to the extent where sometimes everything goes a bit bleached. So it doesn't go black, but it goes white and sort of bleached. So you don't actually see detail, but you can actually still see light as we are operating. So the answer is you can still see light, but you won't see any instruments or any details or any things coming towards you when we are doing surgery.
All right. The next
question
one
here from Puru. Hey Puru, hi. Puru is a ex-Rotarian and an old friend. So I think he asked about cataract surgery and end up using glasses after some time. So unfortunately, the eye does actually change as we age. I think most of the time, I must say, when we do put in a lens into your eye and correct your vision, it's pretty much static for most people. Now, unfortunately, as we age, there are changes that can come about. Sometimes the eye can get more dry, or you can develop other conditions. People might glaucoma or macular degeneration or things which can change your vision and change the power. And subsequently, you may need some glasses to correct. Sometimes you do need that, yes. Okay, I have a question here from Mr. Lu. There's glasses around 2 years ago, necessary to have eye check. Hard to justify imaging eye. Okay, basically, if you can read in this chat, he's talking about perhaps how often you need to get an eye check. I mean, he's in his 30s, still a young man, and he had his glasses around 2 years ago. I think every 2 to 3 years, if you don't have any eye problems, you don't wear, or you haven't had any injury to your eyes, or there's no family history or any eye conditions, I think every 2 to 3 years is fine to actually get your eye test. And of course, the main thing is your own vision. If you find that your vision is not so good or a bit compromised, then it might be time to visit the optometrist or the optician. Now, the question next was, can you do check at the glasses shop or optometrist shop? Okay, so that is a loaded question, because actually in ophthalmology or in eye care, there are different specialists that can do different things. Of course, the ophthalmologist or the eye doctor is the medical doctor, so we can do everything. But there are also, as I mentioned, we have in our practice as well 3 optometrists, which are very useful professionals that also help us very much in looking after your eyes and your vision. So optometrists are individuals who have gone through a degree course to learn about vision care, learn how to check power properly, learn how to diagnose common eye conditions like cataract, glaucoma. They cannot treat, they can diagnose, and they can actually do certain tests to confirm their diagnosis. So optometrists, if you need to actually get your eye tested, I think the optometrist is the minimum. Then you actually go to a glasses shop. A lot of glasses shops have optometrists, and ask for an optometrist. The other person that can actually do your glasses as well is an optician. Now, an optician is different. An optician makes glasses, so they may have a diploma or a qualification that allows them to make glasses, meaning that they know how to dispense glasses following a power. So let's say optometrist is just the power, or the eye doctor has checked the power. They give you a script, then you bring it to the optician. They can then use measurements to measure, and then they'll tell you how to choose the right lens and things like that, and then make the glasses for you. Those are opticians. So if you ask me to check your power, then you can go to a glasses shop, you can go to an eye center like ours, but get an optometrist to check your eye, and then you'll go to an optician to make your glasses. Okay, what should the patient do after cataract surgery? Okay, and what do you mean what they should do? As in what they shouldn't do? What they should do is they should actually use their eye drops as prescribed.
Okay.
I think definitely don't expose the eye to any sort of unnecessary dirty environment, smoky or things like that. Don't rub the eye. You know, those are common sense things not to do during at least the first week, because the first week is the so-called crucial period. If you were to get an infection, the most likely time you're going to get it is in the first week. So what we worry about, that's the most dangerous thing that you can get, is an infection after cataract surgery.
Mm-hmm.
So I think definitely do use the eye drops. Do use the eye drops, but don't expose yourself to unnecessary dirty environment or dirty habits, I would say.
Dr. Lee, can I just ask one question? Because my father-in-law just did cataract removal, surgery recently, and what happened is, you know, that there is some, you know, that the nerve, they feel that there is something within the nerve, so it is make his double visions. So that is what made me I went to KPJ Ipoh today also to ask my neurologist and for further, because you know, we just want to know why suddenly after the operations and is getting worse, and and that's why I need your opinion. And I'm coming back to see you again also on end of August. Yeah.
Okay, have I seen him already?
No.
Oh no, I haven't. Okay.
Today is my first time to come and visit you know, your center.
I see. Okay, I think we have to sort of determine what his problem is at the moment. You said he has double vision.
Yes.
So it could be double vision in two different, well, broad ways. Some people will have double vision when they are looking at things with both eyes open, meaning that
yes, that's right.
the image is separated. So when you cover one eye,
that's right.
Single. It becomes single, right?
Yes.
Yeah.
I mean, if you cover one eye, no problem.
No problem.
You know, eye, no problem. Cover right eye, no problem. But when you open both eye, then you double vision.
Okay. So what he has is, well, the medical term is what we call binocular diplopia, meaning that he's got double vision with both eyes. So that usually indicates a misalignment of the eyes. Okay. So meaning that the eyes are no longer aligned and looking at objects at the same object in the same way. So when there's a misalignment, there can be various causes. So if your father, I believe, a little elderly, does he have a high blood pressure, diabetes, or cholesterol? Yes. So what can happen is sometimes you can have a problem where the blood supply to a nerve that supplies the alignment of the eye actually get affected. So what happens is, for example, there are several nerves that supply movements in the eye. The most obvious is what we call there's a third nerve, the fourth nerve, and the sixth nerve that supplies eye movement. Okay? So any of those nerves, if they get knocked out, either because of diabetes, high blood pressure, or anything, where the blood supply to that nerve is affected, then in that eye cannot move properly. So it cannot move properly, then you end up with double vision like that.
I see.
So if it happened immediately after his operation, it sometimes can be the fact that may not be related to the operation at all, because the surgery itself does not actually disturb the nerves, because the nerves are outside the eyeball. What happens is, during that time, sometimes we can get changes in the blood pressure, especially in elderly people, or the sugar levels go up and down, not so well controlled. And that can be the insult to cause the problem with the nerve and end up with this double vision. So if you've seen a neurologist or maybe even a physician, then you can determine what is the underlying cause. But fortunately, if it's not too bad, and in a lot of cases, they can get better on their own with time. But you need to rule out any major problems in terms of, you know, blood vessels, blockages in other parts of the brain as well, because it's linked closely to the eye, you see.
Yes. Yes. What is the treatment? I mean, it's, let's say that, you know.
Okay. So if we then identify that underlying cause most likely is related to the diabetes or the high blood pressure or the cholesterol levels, then you have to treat that. So you have to make sure those are well controlled and just allow time for the eye to realign or get better. Now, sometimes if after a month, maybe 3 months or sometimes longer, and the eye does not get aligned, you can do surgery to align the eye back again so they don't get double. But surgery is always the last option. Sometimes you can actually have certain glasses made specially where you can actually have what we call prisms put in to realign the images so it doesn't see double, get disturbed so much. But the main thing is to find the underlying cause, because in the more rare occasions is when you can get more sinister problems inside the brain that can cause this misalignment, like, you know, maybe a stroke or, you know, any for lack of a better word, any tumors or things like that. It can actually press on nerves and actually cause problems as well. So we have to rule that out as well sometimes.
He has a bit of mild stroke. That's why he was admitted in KPJ Ipoh.
I see. So that's the case. Then most likely it's the stroke that has resulted in this misalignment of the eyes.
So that means I have to see concurrently ophthalm and also the neurologist together.
I think the neurologist will be able to treat the underlying cause. Ophthalmology is more supportive at this stage because if he's had a stroke, most likely that will be the reason. So the ophthalmologist will be more supportive in the sense that, you know, make sure there's no other eye problems. If you just recently had cataract surgery, make sure that part of it is okay. And if ultimately, a few months down the line, if we still get misalignment, then we can do something to correct that. Yes.
Oh, okay. That's good. Anyway, I'm going to see you also on August.
Okay. All right.
All right.
That's good.
Yeah.
See you soon.
Thank you. Thank you so much, Dr. Lee.
Oh, you're welcome. You're welcome.
Thank you, Wai Teng. Any more questions from the floor? Anyone have any more questions? No?
I think we've had a good session, a good first session, I hope.
Yeah.
Some nice questions, and we hope to actually hear more from other people. If we do have any more further webinars, we tend to do this regularly. We'll send out more information through our social media and things. So if you have other friends or family that you think may be interested, please share the information as well so they can actually log in. So it's like an interactive session, I hope. Next time we'll talk about different things, I hope. Oh, I'm sure we will, I hope. Okay.
All right. If there's no more questions from the rest, just want to pop up a little bit more regarding the to ensure our patients that we will provide a safe environment as we do frequently disinfecting all the tools and equipments after every patient. And then we also install the air sterilizer in our outpatient department, so to ensure to sterilize the air in the especially the lobby and the area where it's more crowded, as well as we also have the open ventilation system. That's why you notice those who have actually came to our center before, you notice that we will leave our main door wide open as compared to before, as well as our back door. So you have proper ventilation, you know, so that if there's any virus or bacteria in the air, it will just be flow out. So like what Dr. Lee say, we will do this more frequently and regularly. So stay tuned to our next webinar. Like our Facebook or our Instagram page for more updates. So we will have other resident doctors in line for our next webinar with different topics as well. So thank you everyone. Before we log off, if possible, can we have you all turn on your camera so I can take a snapshot?
All right, okay.
Since we cannot have it physically, so I will appreciate those who are not in your pajamas, if you don't mind. So you can just turn on your camera. I will just take a screenshot of everyone.
Well, some of the profile photos here look very nice as well anyway.
If you prefer your profile photo, is okay. Alrighty. Can we have more people to turn on your camera?
Okay.
Okay.
So you're doing it, right, Anna? Okay.
Yeah, I will do a screenshot. Okay. Smile. One more. That's good.
Okay.
All right. Awesome.
Thank you.
Thank you, Dr. Whitley. Okay. Thank you, Anna.
Thank you. Nice to see you all. Hope to see you all again next time.
Thank you. Bye.
Right,
Good night.
Good night. Bye-bye.
Bye-bye.